Hello everybody, I am Dr. Deeksha Pandey and you are watching Urogynecology for Beginners. And today I am so proud and so happy to have an expert with us who does a vaginal hysterectomy, non-descent vaginal hysterectomy with a different technique. So he is no other than Dr. Pranadeep. And Pranadeep, would you like to tell something about your kind of NDVH, what you do? Then we can proceed into further discussion.
Yes, ma'am. Thank you, ma'am. Hi, everyone. Today I am going to discuss about clampless and sutureless non-descent vaginal hysterectomy. And it is a little different from the suture and with clamp. Here I am using a bipolar clamp instead of suturing and clamping and then suturing. This will coagulate and cut the tissues. And even at the corner surgery, especially after the uterine artery, with the suturing you will have difficulty in taking sutures and clamping it, and it may slip. But whereas here you can, without any fear or fear of slippage, you can coagulate and then cut.
So here I will interrupt Pranadeep and tell about my journey of this NDVH with the clamp and without clamp. So if you are following our channel, you would realize that many years ago or two or 3 years ago, I have done a sort of debate or discussion about clampless and with clamp or with bipolar clamp vaginal hysterectomy. That was the time when I was sort of against it. I thought it is not as good as people talk about it. But since Pranadeep has learned and come and started doing it, I have developed a lot of confidence in his technique, how he does. Yes, it requires a little bit of patience, but if you compare the overall time taken, it's not that because you are taking small pedicles in one go, it takes more time. No. When we compare the entire time, it is almost same for both the procedures, 30 minutes. There the clamps are bigger, but again you have time is taken to suture them also. So time is almost the same. So actually the person who once upon a time said that no, this is not a good technique, I have also started seeing and saying that it is actually a good technique which all of you, if you have a clamp or bipolar clamp, you can try it. The only thing that we have to have some precautions. Pranadeep, can you tell what precautions we need to keep?
Before that, ma'am, I just want to, here we are using 5 mm bipolar clamp.
Okay.
There are 10 mm clamps also, where the surgery can be even more fast if you want. And but 5 mm you will have a better coagulation and you will be confident.
Yes.
And the precautions what we take is by doing, especially in the uterine artery, we know that ureter will be closed. So we will pull the uterine artery over the cervix and then do coagulate it.
Because we are worried here, that was also one of my concerns that time, that what about the thermal injury to ureter or vaginal walls all to bubble. And where I find it very useful, so I learned it from Pranadeep. I have also started doing the same. Where I felt it, it was very helpful, especially when you have to remove the ovaries while you are handling the IP ligament, which is not a very easy step when you are following the traditional hysterectomy steps.
Though we say it's clampless, it is not completely clampless. No? At the corner structures, I also use clamp
yes.
so that it won't slip. So first I will clamp and coagulate medial to the clamp and then release it and see whether it is bleeding or not. Then I will release partially and hold with one Alice and then see if it won't bleed, then only I will release.
So all these steps, if you are finding them difficult to understand, he is going to show you one video of the same hysterectomy technique where you can understand and learn it. When you are following the traditional approach of NDVH, only one thing I think that beginners should start learning from there, because that is the place where you can learn anatomy very well. Okay, once you are well versed with the anatomy, then you can go ahead and do the bipolar or biclamp technique.
I completely agree with you, ma'am. Definitely, after knowing the suture and how to suture and where to use the clamps, you learn this biclamp method.
So if I have to summarize this, basically at least 10-12 hysterectomy, you should be well versed with the traditional approach. And then if you have facilities and you want to improvise on your technique, you can always use a clamp technique and see what works better for you. Or it may be a combined approach also. You can use both the techniques. So today we are going to show you one surgery done by Pranadeep in his own voice. I hope you enjoy it.
Thank you.
After painting and draping and catheterizing the patient, cervix is held with 3 Alice forceps and then twisted on either side clockwise and anti-clockwise, and with the help of index finger you stretch the uterosacrals. All this is done to relax the uterosacrals so that you will get space. Now using bipolar clamp, I will coagulate at 3 o'clock position first, 1.5 centimeters from the external os. Why at 3 o'clock position? Because the descending cervical artery branches will come there, and these vessels, if you coagulate first, there won't be much bleeding. After coagulating and cutting using fine scissors, you can push that area with the speculum, sim speculum. After that, you can move towards 12 o'clock position and then towards 9 o'clock position. Most of the times, these vessels you will see at 3 o'clock and 9 o'clock position. So, always better to do at 3 o'clock and 9 o'clock and then cut in the center so that there can be minimal bleeding. Now here I am coagulating even Meckenrod ligaments and some vessels which are bleeding. I am coagulating and cutting. Once you coagulate them completely, once you coagulate and cut, the pubocervical fascia is now separated and from the cervix using fine scissors and then pushed upwards using the sim speculum. With the help of sim speculum, I am trying to push the bladder upwards. In order to open POD, what I did was I pull out and in the cervix with the help of the Alice forceps. I can see a fold of vagina in the posterior fornix. So over the just below the fold, I will catch with Alice. Then using the bipolar clamp, I will coagulate. Why I am coagulating here is most of the times we observe the bleeding from the posterior vaginal wall during vaginal surgeries is more. So first I coagulate and then using fine scissors I will cut in front of the coagulated area so there will be no or minimal bleeding. Even after opening the POD, making sure that there are no adhesions, I will coagulate at the angles of the POD. You can see here coagulating at both the sides of both the angles of the POD. After coagulating, then I will insert the speculum into the POD. Now posteriorly, bubble is protected as well as bladder with sim speculum. Now the Meckenrods and uterosacrals are coagulated twice or thrice depend upon their length and safety margin, then cut medially to your coagulated area. Always using your index finger, feel for the uterosacrals posteriorly, and if still remaining, you can coagulate and cut. You can do bit by bit on either side. Even though the procedure appears lengthy, but here there is no tying of pedicles, so the time taken is very less. Using suction cannula, you can suck the fumes so that the visibility will be clear. And even using suction, any fluid or blood can be sucked otherwise the clamp sometimes it won't work in a wet field. I am repeating the same procedure on the right side. You can see I am using my left hand index finger over the bike clamp so that my instrument tip always lies as close to the cervix as possible. Here I am trying to push the bladder upwards after the pubocervical fascia is completely separated. I am doing sharp dissection. Now I can see here branches of uterine artery which I am coagulating here. Now the uterine artery is also coagulated and cut. Now on the right side, any uterosacral remaining are coagulated and cut. This I know by putting my index finger in the posteriorly and feel for uterosacral ligaments. After coagulation, cut using fine scissors medially to the coagulated part. Now using speculum, gently push the bladder as much as possible. Then you can see the UV fold. UV fold can be held with long artery forceps and cut with fine scissors boldly. You can open the anterior pouch. Insert the speculum inside. Then you can clamp uterine arteries at the level of internal os. Always hold the uterine arteries onto the cervix or uterus so that the heat won't spread to the adjacent areas. Here on the left side you can see clearly the uterine artery coagulated at two different places. Usually I will do at two or three different places and then cut medially towards the uterus. This patient has two small fibroids at the anterolateral on the left side. So first I give a small nick and then remove using towel clips those fibroids. It will be easy to clamp corneal structures after removing the fibroids. Always before going for coring, look for any vessels are there in the corneal area or any retrained branches are there or any uterovarian anastomosis vessels are there. That should be looked and they should be coagulated and then cut. Once you are sure that on either side the vascular pedicles are coagulated and cut, then you can go for coring. Usually I prefer using 22 number blade starting just above the uterine artery insertion on either side like a wedge towards the center of fundus. Here on the right side still some of the vessels are there, so we are coagulating again and then cut. As you start cutting the uterus, you can see the uterus will just pop out. Till now, we have not used any clamps, but in the cornal area, I will use a long clamp to hold the cornal structure on one side and then cut using scissors after making sure no bowel or any omental adhesions to the uterus. Once I cut the uterus, the cornal area I will keep inside along with the clamp. On the remaining part of the uterus, I will hold it and pull outwards and coagulate the cornal structures. Here I can see the fallopian tube on the left side. I am holding the fallopian tube with Babcock's and separating it after coagulation. Now I am cutting the round ligament on the left side. The left cornal structures are being coagulated and cut. Any bleeders or vessels should be taken care of adequately, because once you cut and coagulate and cut this area, as the cornal structures after cutting will retract upwards and inside, so you should be very careful. Usually the cut end of the round ligament I will hold with an Alice, so that in case if there is any bleeding, I can coagulate then and there itself. The uterus is released from all its attachments and then delivered out. Now the fallopian tube is removed after coagulating the mesosalpinx and then cut. The ovarian ligament should be coagulated adequately, as well as the vessels in the mesosalpinx area. Most of the times, in order to protect the bowel and omentum, I will keep a wet gauze behind the pedicles or behind my instrument bipolar clamp, so that even if the heat spreads or the thermal energy spreads, it will spread to the gauze but not to the adjacent organs. Now you can see on the right side the clamp which I have kept inside. Now I am pulling it out and I am keeping a gauze piece behind the cornal structures between the bowel or abdominal organs and the cornal structure. Here I am coagulating the fallopian tube on the right side and cutting towards the fallopian tube. After removing a fallopian tube, now on the right side, ovarian ligament, round ligament and mesosalpinx coagulated, and any vascular pedicles or vessels which are bleeding should be taken care of now. You can see I am coagulating round ligament at 3 different places before cutting. Now ovarian ligament is also being coagulated on the right side at 3 different places, though closely. You can see I am holding the round ligament with an Alice forceps so that in case if there is any bleed, I can coagulate it. If you won't hold, then it will go inside and it will be difficult to see once it runs. Now always remember to remove the gauze piece which you have kept behind your instrument or inside the peritoneal cavity. Now holding the vaginal wall edges both the angles and posterior vaginal wall as well as anterior vaginal wall using vicryl or absorbable suture. I am closing the vault. Usually I will start at the left side angle and then go towards the right. I will interlock the sutures so that if there is any bleeding, that will take care of. And at the angles, better to avoid to go too much lateral, as we know that ureters are nearby. So to summarize, initially first with Alice I will, after holding the cervix with Alice, I twist clockwise and anti-clockwise so that the uterosacrals will get stretched and relaxed. Even with the index finger I will try to stretch the uterosacrals, and next always coagulate near to the uterus or cervix and then cut medial to the part you have coagulated. Then when you are coagulating the uterine arteries, try to move the uterine arteries onto the cervix so that there won't be any thermal spread. And while cutting the cornual structures, make sure that all the vessels or vascular pedicles are adequately sealed, and even try to put a wet gauze piece behind your instrument or behind the tip of your instrument so that there won't be any bowel or bladder injury. So thank you for watching the video.